questions. My name is Shaylind Benson. I'm a naturopathic doctor, and what that means is that I did go to a 4-year medical school, but my profession focuses more so on diet, lifestyle, and preventative factors, botanical supplements, etc., to help us to essentially get to a more optimal state of health. And we do oftentimes work with the conventional medical system, so it's not opposed to it per se. It's something that could be integrative with your current conventional care. So today I'm going to be talking about the foundations of prostate cancer and also an integrative approach to it. I've been a naturopathic doctor working for Life Extension for about 9 years now. And I have been mainly focused in the cancer realm for the past 2 to 3, although I've always had a significant interest in it. And so Dr. Dave Walker did a prior presentation for this group, and I'm going to use about half of his information, maybe a little bit more, and then I have done some updates as well to that and added some additional information. Feel free at any time to interrupt me if you have any questions. I don't want people to forget until the very end, although there is some echo in that kitchen area, so I may ask you to repeat it. And I'm not sure if I'll be able to see the chat while I'm presenting, so if questions are presented in chat, feel free also to interrupt me as well and let me know. Let's begin. Oh, first of all, I do want to mention that as a financial disclaimer, I do work for a company called Life Extension. I'm not here to sell any services or products. I'm just here to give education. But the company does sell lab work and supplements. But we do offer education as a free resource to our customers. So that is something that I am involved with, and it is my role at the company that is allowing me to present with this group today. So let me try sharing my screen. One moment here. Can everyone see this?
Yep.
All right, excellent. All right, let's get started. So I'm going to be talking about a lot of studies today, but we have to keep in mind that studies are not definitive. They're a piece of the puzzle that just gives us some information to progress towards having more knowledge about something. And so sometimes you'll find that some studies do conflict with each other. So over time, we have to look at the overall body of evidence to come to a conclusion. And I'll also be talking about a lot of correlational studies. And what that means is that it's not a cause and effect. It means that someone did this and this happened. Doesn't necessarily mean that what they did caused something to happen. It just means that there's an association. That still could be useful data because it could help us guide us until we do find a definitive answer to information. But what we're going to be talking about is the many phases of prostate cancer. What that means is essentially each individual's prostate cancer is unique and different to that person. And I'll explain various reasons why that's true. We will discuss the pathogenesis of prostate cancer, which is essentially its metabolic structure, how prostate cancer utilizes energy and how that allows cancer to happen in our bodies. We'll talk about how lifestyle can impact our risk of prostate cancer. There's various things we could do both before and after prostate cancer diagnosis that could assist us in our journey there. We'll talk about some advancements in diagnosis, monitoring, and treatment. This really isn't my focus. I'm not going to talk about conventional treatment much, but I'll talk about some newer kind of innovative options that are at least interesting and should be at least discussed. We'll talk about using supplements and nutrition to potentially slow down or stop prostate cancer development or manage its aggressiveness. And then we'll talk about using drugs that have been repurposed to target prostate cancer cells, meaning drugs that are not approved to treat prostate cancer, but have been found to be useful. So let's talk about some key findings in prostate cancer. So it's estimated that this year, 288,000 men will be diagnosed with prostate cancer. It's about 1 in 6 men within their lifetime. This year, it's estimated about 35,000 men will die of the disease. It's the second leading cause of prostate cancer death in American men. And in the future, it's plausible it may be the leading cause of cancer death in American men. And the reason why is because lung cancer is the number one cause, but those rates have been decreasing due to less smoking. So it's possible that this scenario may change in time. And about 1 in 36 individuals who have prostate cancer will die from it. And we could see that these incidents are increasing over time from, say, 2019 and 2020. Continuing on. There is some good news, though. If you're diagnosed with local or regional stage prostate cancer, meaning prostate cancer that just remains in the prostate and has not spread outside of that capsule, there's a near 100% 5-year survival rate. And if we look at it from an even longer period of time, because prostate cancer is considered to be a 15-year disease, there's a 95% survival rate. And that's why I'm a big proponent of monitoring by doing things like testing PSA, which for a period of time, one of the main leading cancer organizations says, well, men shouldn't really be monitoring their PSA because it's resulting in overdiagnosis and overtreatment. So there was about a decade or so where they suggested to not test PSA. Well, until we found out that the rates of aggressive prostate cancer substantially increased, and then they changed the recommendations. Because if that prostate cancer is allowed to break through the prostate capsule and spread to the lymph nodes, the bones, the liver, the lungs, the brain, you could see the significant difference in survival rate. In other words, it's best to catch this early. It's best to catch it before it spreads, because we could have substantial survival. In a lot of situations, men are going to die of cardiovascular disease before prostate cancer if it's allowed to be treated in the regional local stage. So here are some symptoms of prostate cancer, but here's the problem with this. These symptoms typically don't start until late stage prostate cancer. Prostate cancer that's become aggressive, that's been there for a long period of time, that has begun to spread around. Because a lot of these symptoms are very similar to an enlarged prostate or prostatitis, inflammation of the prostate. For instance, bloody urine, that's more likely to be prostate cancer, but that could happen with urinary tract infection, for instance, and it could happen potentially with significantly enlarged prostate. But the number 2, 3, and 4, the inability to force out urine, urinary problems, unable to urinate, well, those are all symptoms of benign prostatic hyperplasia, or BPH, or an enlarged prostate. Those are not specific to prostate cancer. You could have pain and discomfort with urination. You could have a burning sensation, but again, those could be possible in prostatitis as well. Erectile dysfunction is a little bit more specific to prostate cancer. Frequent urination at night, that can involve prostatitis or urinary tract infections, or BPH as well, as that prostate, as it gets very enlarged, starts pressing into the bladder. One symptom that is a little bit more specific to prostate cancer is weariness or fatigue, because cancer is much more highly metabolic compared to normal healthy tissues, meaning that essentially it utilizes up your energy reserves, and so people often end up in a fatigue state. And then number 10 is a little bit more specific to prostate cancer, because once prostate cancer has spread to the bones and it has begun to necrotize or destroy that bone structure, you could start to get lower back pain. And that lower back pain could be quite significant. In fact, over-the-counter medications are oftentimes not sufficient to manage it. It typically requires some very strong pharmaceuticals such as morphine. So in the past, and it's still used today, but in the past they mostly used what's called a Gleason score. Essentially what a Gleason score is it essentially compares the cellular structure compared to normal cells, because cancer cells are very chaotic. You could see this on the right-hand part of the slide, where Gleason pattern 1 is small, uniform. It looks like normal cells. It's very well differentiated. And you could see down at the very bottom at Gleason 5 is very chaotic, as cancer is essentially a chaos in nature in certain ways. But that's been upgraded to the grade group system, as you could see on the top left. Because one of the problems with the Gleason score is that you'll see with grade group 2 and grade group 3, those are both Gleason score 7, which is considered to be intermediate. Well, the problem is that it has different presentations. A Gleason 7-3, meaning that one of the patterns is a 3 and one of the patterns is a 4. is much different in risk compared to a Gleason 7 that's predominantly pattern 4, which again is much more chaotic. So they've separated that into the grade group system, which is from 1 to 5. Essentially, grade group 1 is low risk. Groups 2 and 3 are intermediate favorable or unfavorable risk. And then grade group 4 and 5 are higher, very high risk. We could see at the very bottom left, after people in these grade groups, after they had their prostate removed, a radical prostatectomy, we could see the potential reoccurrence rate of cancer. Because the unfortunate thing is that if you remove prostate cancer, such as through a removal of the prostate or through radiation, there's always the possibility of cancer stem cells remaining there. And because these higher grade and higher Gleason prostate cancers are much more aggressive in nature, there's more of a chance of that prostate cancer reoccurring. So we could say in the low risk group, after they've had their prostate removed, there's a 95% chance that they're not going to have a reoccurrence of the prostate cancer. Compared to grade group 5, very high risk, there's only a 12.4% chance that they're not going to have reoccurrence within that 5-year time frame. But again, this is only using a radical prostatectomy. This is not utilizing other treatments such as androgen deprivation therapy, focal therapy, etc. So another way that cancer is very individualized is not just based on the grade group or Gleason score of it, but actually there's a wide variety of different genomic or genetic profiles that could happen. And you could actually directly test for this. And these genetics of prostate cancer can actually change over time as cancer gets mutations, more mutations to it. So actually, if someone is diagnosed with prostate cancer and they test the genetics of the cancer to see if there's mutations or variants, it's advisable to continue to do that every year or so to see if that changes and allows potentially newer, more advanced, or more researched therapeutics to potentially assist. In addition, we could also test our own genetics to see if we have a variant or a mutation that allows us to be more susceptible to prostate cancer, such as a BRCA mutation. So this is testing that you could potentially do now, especially if you do have a family history of prostate cancer and you don't already have prostate cancer. Well, you could test to see if you're at higher genetic risk. And if you do have prostate cancer, you could have your biopsy sample sent out for genetic testing to see if it has mutations or variants that could give you potentially more treatment options. Here's an example of testing a biopsy sample for its genetics. And you could see that they've identified certain therapies based on the genetics of this individual's cancer treatment. So sometimes we don't see a significant amount of variants that potentially have treatment potential, but sometimes we do, and it just gives us a wider toolbox to potentially manage an individual's situation. In addition, it really matters where the prostate is localized, where it is. And again, this is why we emphasize so much early detection and management. Even as a naturopathic doctor, it's something I encourage people to do. The main thing to do is prevention. Well, if prevention is too late, then the best thing is early treatment and management. Because again, in localized prostate cancer, 80 to 85% of prostate cancer is detected in the local or regional stage. What that means is that for the majority of people who are diagnosed with prostate cancer, we could potentially manage the risk of metastasis and aggression of this cancer by continuing to monitor it and treat it. Many men, although they'll be disease-free in 5 years, after that 5-year mark, 20 to 30% will relapse, meaning the PSA starts increasing, and then it has to be treated or managed again. But again, the good news is that 15-year survival rate is 95%. At that point, if you're diagnosed with prostate cancer when you're 70 years old, you're probably more likely to have your mortality affected by cardiovascular disease than you are prostate cancer. But if that prostate cancer is allowed to break through the prostate capsule and spread to other structures, you could see how vastly different the survival rate is. For instance, the median survival, if it gets to the liver, is 14 months. The lymph nodes, which is the first site that cancer typically goes to, or prostate cancer, is 32 months. And then the next most common site after the lymph nodes is the bones, because the bones have growth factors that really attract the cancer cells to them. So the point of this slide is that it's best if prostate cancer is detected early, before it's spread, because then it's a much more optimistic situation compared to when it's not monitored. People are not testing their PSA. Eventually they do, or potentially they have significant back pain. They go to the doctor, ask why, and then they find out the cancer is all over their body. Well, at that point, they're in a much more of a problematic situation compared to if we could get it before that happens. So what is prostate cancer and how does it happen? And it seems like a simple question, but one day I had an individual ask me that. He said, what is prostate cancer? And I think, it's important to know. What it is it's uncontrolled or malignant cellular growth within the prostate gland. Generally speaking, our cells go through about 50 replications before they're destroyed through a process called apoptosis, or programmed cell death. One of the reasons why our body does that is because over time our cells can develop genetic mutations due to irritants, for instance, oxidative stress. Well, we don't want to be replicating damaged cells with damaged DNA, so our body says, okay, after about 50 replications, you should die. And that's what should happen. Well, with cancer cells, they lose that programmed cell death capability. They lose that ability to destroy themselves, and so that therefore they continue to grow and flourish. Generally speaking, about 99% of prostate cancers are what's called adenocarcinomas, which means that they develop from the glands in the prostate that make prostate fluid, which is then added to semen. And there's other types of prostate cancer, but the vast majority of are adenocarcinomas. And generally speaking, the hallmarks of cancer is that you have uncontrolled growth. Angiogenesis is new blood vessel development because they need to be able to feed themselves to continue to grow and thrive. And apoptosis evasion, meaning they lose that programmed cell death capability. So what are the risk factors for prostate cancer? Well, there's actually still a lot we don't know. Certainly age is a component, and one of the reasons why is because a concept called immune senescence. What that means is as we age, our immune system gets old and it becomes less functional. We could see direct evidence of that when how chickenpox returns as shingles in the elderly population, as that virus really never goes away, but when our immune system becomes old and less functional, it's allowed to escape out of the nervous system and express itself as shingles. Well, if our immune system is not working as well as it used to, well, there's a decreased ability then for our immune system to fight off cells that shouldn't be there, such as cancer cells. So that's how age is one factor. Race, the incidence is up to 70% higher in Black men for factors that we're not even completely aware about. In addition, in Black men, it's likely to be more aggressive as well. We know that urbanized environments is a risk factor. They found out this by taking rural places that have become urbanized, more city-like, and they notice that prostate cancer increases when that happens, likely because of a higher exposure to environmental pollutants, toxins, and chemicals. In family history and genetics, is actually only about 5 to 15% of prostate cancer, meaning that the vast other risk factors of prostate cancer are not genes that you're born with. But that does increase if you have a significant family history. If you have 2 relatives or more with a history of prostate cancer, that risk goes up 4 times. So genetics does play a component of it, but overall genetics is a very low factor in overall cancer risk, and that's including prostate cancer. Another factor in risk is environmental toxins and other chemicals such as pollutants. Eating habits and weight, obesity is a significant risk factor for all cancers, including prostate cancer. Smoking is associated with more aggressive prostate cancer. And one thing that a lot of prostate cancer organizations don't really talk about much, but infections actually is a risk factor for prostate cancer, such as prostatitis and human papillomavirus, or HPV. So I got a question. When it comes to prostate cancer, we say if you go to a surgeon, the first thing he wants to do is cut. And if you go to a radiation oncologist, the first thing they want to do is zap the prostate. So if a prostate cancer comes to you, what is the first thing you suggest? Well, there's a lot of factors that depend. For instance, grade group 1 or Gleason 6 could oftentimes be managed through what's called active surveillance, meaning that you don't do anything. You don't do radiation, you don't cut out the prostate, you just continue to monitor the PSA, because a grade group 1 or Gleason 6, those prostate cancer cells look pretty much like normal cells. And the risk of it breaking out of the prostate capsule and spreading around the body is very negligible. We'll talk about that in a moment. Now, on the other hand, if a prostate cancer is intermediate stage, where it potentially does have a higher risk of breaking through the prostate capsule and spreading around. Again, it's very important that we manage it before that happens. So if someone is Gleason mostly 3 and 4, meaning that they're Gleason 7, but it's mostly 3, meaning mostly like normal cells, well, then sometimes they could still be managed through active surveillance. There's tests such as Polaris that could give us information about the genetics and the aggressiveness of that to tell us if it really should be treated through something invasive like that. If it's Gleason, if it's a higher grade group, such as grade group 3, 4, or 5, then yes, it should be managed before spread has come. Because then if they don't like to use this word in oncology, and we talked about the significant reoccurrence rate. But generally speaking, if a prostate cancer is localized, it's potentially curable. If a prostate cancer has spread and metastasized, it's no longer curable, it's manageable, meaning that you could potentially slow it down. You could potentially even do that for a long period of time, but you can't cure it at that point, at least currently. There's some promising future applications. But if you get it at the local regional stage, yes, there's a possibility of reoccurrence. So they like to use in conventional medicine the word remission, but it's potentially curable. So I do suggest if people have a potential aggressive cancer, a cancer that has the potential to spread around, I do suggest to potentially zap or remove the prostate. I'm not going to talk about that much though today because there's people who could give you much more detail and information that have experience with doing those things compared to myself. I don't really deal with a lot of radiation or prostatectomy, although I am informed about it. In regards to genetics, another thing I would like to mention is if you look at this, this image to the right, you see at the bottom they put modifiable factors, diet and lifestyle, and the environment. But if you look at the top where they mention unmodifiable factors, you'll see that they have genetic factors. And that's actually not really true that that's unmodifiable. It is true that you can't remove the gene, at least currently, until CRISPR technology becomes prevalent. But you can modify genetic expression through a concept called epigenetics. And what that means is that our diet, our lifestyle, the things that we do, could modify the expression of the genes that we're born with. Just because you have a genetic variant that says you're at a higher risk of having cancer does not mean that you're going to get cancer. Our epigenetics, the way that we influence the genetic expression, can influence the genetics that we're born with in regards to cancer risk and development. So there's several different environmental toxins that have been linked to higher prostate cancer risk. One of them is one I'm sure you're all familiar with, BPA, bisphenol A, from certain types of plastics. So if you are drinking or cooking with plastic containers, make sure they're BPA free. But other toxins that are related are workplace hazardous toxins, which mostly are petroleum byproducts, such as xylene, toluene, benzene, and styrene. One of the things that you could actually do is you could test the amount of these toxins in your system if you're concerned they may be playing a role in your risk of development. And I have an example to the right of some of that testing, and you could see in this individual, the very first one in red, they have very high levels of xylene in their system. So how do normal cells become cancerous? What causes a growth-regulated normal cell to become a growth-dysregulated cancer cell? And the conventional theory is that over time, we get more mutations in our genes, and that potentially eventually overcomes the genetics so that they lose that apoptosis. So we could see, for instance, in this example, we have a normal cell that undergo 1 mutation, 2 mutations, 3 mutations, until eventually their DNA is so damaged that they become malignant and lose that apoptotic ability. And we'll talk later about some of the things that could lead to these mutations. But then recently, not necessarily recently, because this has actually been talked about by Dr. Otto Warburg since the 1950s, but Dr. Thomas Seyfried has brought recent interest into this. But one way this potentially can happen is that our mitochondria could be damaged, and that damage could change the way they metabolize nutrients. And when our mitochondria become damaged, they release oxidative stress, reactive oxygen species. And those could lead to mutations of the genetic material of the mitochondria and the nucleus in our DNA and create these type of malignant cells. So mitochondria is in all of our cells in our body except for red blood cells. And what they do is they help us generate energy in the form of ATP. And ATP is necessary for the growth, development, and function of all of our organs, our brain, our liver, etc. But our mitochondria also play a role in cell signaling, cell differentiation, cell death, as well as maintaining control of the cell cycle and cell growth. And I have a question, one moment. Someone said in their case, it was to inform yourself, ask questions, and get a second opinion. Yes, always. Make sure that not only you inform yourself, but you do ask questions, and a doctor who's not willing to answer your questions, definitely get a second opinion. Even with a doctor who does answer your questions, if you're going to be doing something invasive, like removing your prostate or radiation, definitely get a second opinion, especially because we'll talk a little bit later on that there's potentially some alternatives to those things called focal therapies. There's not as much research with those, but they appear to be potentially much less invasive and much less capability of producing adverse effects such as erectile dysfunction and urinary issues. So yes, always educate yourself, ask questions, and get second opinions, sometimes even third opinions. And I would also actually encourage that with biopsy samples too. You get a prostate cancer biopsy sample, you send out to one organization, send it out to the second one. They may potentially do a better job of analyzing it and give you more information. So in regards to mitochondria, they did a study. And essentially, I'll summarize this real quick. But what they did is they took the nucleus, what contains the genetic material of a cell, and they put cancer nucleus into normal cells. And what they found is that when those cells divided, they are actually normal cells. That's number 3. But when they took a normal nucleus into a cancer cytoplasm, meaning the other material within the cancer cells, those were still cancer cells. Essentially what this suggests that it's not the nucleus, the genetic material in the cell that determines its ability to divide and replicate as a cancer cell, but it's actually the mitochondria that is responsible for regulating that factor. And they've done studies also where they injected cancer mitochondria into normal cells and they turn cancerous. The reason why I'm even bringing this up is to discuss how important it is to help support our mitochondria. So the mitochondria are especially susceptible to nutrient deficiencies, environmental toxins, and oxidative damage. They're also sensitive to what's called hypoxia. And what that means is low oxygen, such as sleep apnea, lack of exercise, cardiovascular disease. When we have low oxygen in our system, it introduces dysfunctional feedback, resulting in mitochondrial damage that exacerbates oxidative stress, which could result in further mutations and inflammatory signaling. So what could you do to support your mitochondria? So part of the mitochondria that helps to produce energy relies on having CoQ10 and NAD as cofactors. And those are available as supplements. And these are things that do decrease with age, the amount of CoQ10 in our system and the amount of NAD. We could decrease our toxin exposure. For instance, eating organic fruits and vegetables, testing to make sure that if we do have toxins, we have a way to potentially remove them, such as heavy metal chelation, or potentially even remove ourselves from a very urbanized toxic environment, if that's even possible. You could also utilize nutrients to help to protect the mitochondria from oxidative stress and advanced glycation end products, such as lipoic acid. And there's nutrients that can help to support with the mitochondria producing energy in the form of ATP, such as L-carnitine. And then you don't even necessarily need supplements to support mitochondrial function. You could do so through strength training and building muscle mass. Is one strategy you could do even if you don't have any money. So before we begin into the next section, does anyone have any questions for me? Okay. I'm sorry?
Yes, I have a question with respect to the CoQ10 and maybe with other things too. If it's helping the mitochondria, the prostate cancer cells have mitochondria also. I mean, my situation has been before you have prostate cancer, there is some evidence that taking a lot of vitamin D may actually increase your risk of getting it. But once you've got prostate cancer, taking more vitamin D may actually help the situation. What's the case for CoQ10?
Well, we'll see later on how CoQ10 has actually been shown to be beneficial in people who have cancer. One of the ways that do so is supporting the immune system. But another thing to think about is that if we have the surrounding microenvironment that surrounds cancer cells, meaning our normal healthy cells, if those cells are able to function as effectively and efficiently as they can, what that does is it provides a hostile environment for prostate cancer to continue to flourish and grow through that microenvironment. If the surrounding microenvironment nearby cancer cells is lacking energy because they don't have CoQ10 and NAD, if they're in an inflammatory oxidative state, well, they're essentially weakened and they have the ability for those cancer cells to destroy them and steal their nutrients as one way of looking at it. So generally speaking, even with people with cancer, I encourage people to support the function of their healthy normal cells because that gives less opportunity for cancer cells to irritate them, break through, and invade through that microenvironment. So, and that's exactly what we're talking about right now, how to nurture your microenvironment. And there's different ways and factors that you could do so. For instance, we're going to talk about regulating its excessive insulin and sugar, managing inflammation, balancing your hormones, managing low oxygen or hypoxia, maintaining a diet that's rich in polyphenols, flavonoids, healthy fats, and making sure you have a sufficient amount of exercise. So prostate cancer actually doesn't feed off of sugar. A lot of cancers do, but some cancers don't, and prostate cancer is one of them. However, prostate cancer is still very sensitive to insulin resistance. So we want to be insulin sensitive. What that means is that our cells are sensitive or react quite well to the function of insulin. The problem is that with high sugar diets, metabolic syndrome, prediabetes, and diabetes, with increased insulin production to try to get that sugar into cells, the cells can eventually become resistant to that insulin, so the pancreas has to produce more and more insulin to get that sugar into cells. And that's what they found, is that people with insulin resistance are at a higher risk of prostate cancer development. Not only that, but high insulin levels, or potentially, even ignoring the insulin component and ignoring that sugar doesn't necessarily feed prostate cancer. We do know that eating a large amount of carbohydrates or sugars decrease our immune system. They decrease the capability of a white blood cell called a neutrophil to engulf bacteria. Well, neutrophils also target cancer cells or unwanted or desirable cells. They release a catalytically active neutrophil elastase to damage cancer cells. So in other words, even if prostate cancer doesn't feed off of sugar, if we have a very rich carbohydrate-based diet and we're spiking our blood sugar, spiking our insulin, well, that's not good for our immune system, which is important for us to help fight off cancer. And they did a study, and what they found is that men who have the most amount of insulin resistance were almost 3 times more likely to have prostate cancer than men with the lowest amount of insulin resistance. And the men who were very sensitive to insulin, meaning that they didn't need to produce much, had a 65% reduced risk of prostate cancer. So generally speaking, the standard insulin reference range is a 2.6 to a 24.9. Life extension has optimal ranges for certain blood values where we believe healthy people or people concerned with wellness should be. And we believe that fasting insulin, based on this and cardiovascular disease and other factors, really should be less than 5 to 7, because you really shouldn't need a lot of insulin if you're in a fasting state. So this is something we encourage people to ask their doctor to test, is when they have their physical exam, ask your doctor if they could test your fasting insulin so you could see if you're dealing with insulin resistance. Another factor that we could regulate is chronic inflammation. So Studies have shown that there's an increase in relative risk in men with prostate cancer, or risk of prostate cancer, and men with a history of clinical or symptomatic prostatitis, meaning inflammation of the prostate. They've also found a higher risk in men with sexually transmitted infections, such as gonorrhea and HPV or human papillomavirus. And one of the reasons is potentially due to inflammation inducing oncogenesis, or damaging our DNA and allowing those cells to lose their programmed cell death. And we see with inflammation that there's an upregulation of enzymes that create inflammatory protein byproducts, such as COX-2 and 5-LOX. 5-LOX is an enzyme that's actually very highly expressed in prostate tissue, and we'll see later on how that is influenced by our diet as well. And so you can measure the amount of inflammation in your body, and we also encourage people to ask their doctor to test this by measuring C-reactive protein. A lot of doctors, well, not a lot, some doctors will test this for cardiovascular risk because blood vessel inflammation is can contribute to cardiovascular disease. But C-reactive protein actually is an inflammatory protein that's involved in nearly all aspects of inflammation. So that includes prostate inflammation, which we measure by testing PSA. Continuing on. They've actually found a link between cardiovascular disease and prostate cancer risk. They did a study over 6,390 men over a 4-year period of time. And what they found as a coincidental part of this study is that men with cardiovascular disease had a 35% greater risk of developing prostate cancer over time and a 24% greater risk of being diagnosed within the first 2 years of the study compared to men who did not have heart disease. So if we're looking at this from a preventative perspective, it's not just managing our prostate and our mitochondria, but it's managing our cardiovascular system, our heart, and our blood vessels as well. Another component that may play a role in prostate cancer risk and development is imbalances of our hormones, such as a hormone called DHT, or dihydrotestosterone. Our body converts testosterone into dihydrotestosterone through the 5-alpha reductase enzyme, and there's certain drugs that block that enzyme because high levels of dihydrotestosterone are associated with baldness and enlarged prostate. So some men who don't have prostate cancer will use these blockers to shrink the prostate to help them relieve their urinary problems. And what they did is initially there was some controversy because they found that in early studies, these DHT blockers, while they did lower the risk of prostate cancer by about 25%, they were linked to more aggressive prostate cancers. But what they did is in further evaluation of those studies, what they actually found was there was a biopsy sensitivity issue. And actually the men were on these drugs, because it shrunk the prostate, the cancers were actually just easier to find through a biopsy. So what they did is after they removed the prostate of these men, they actually found that these DHT blockers had a 27% reduction in high-grade disease. So they found, no, it didn't increase aggressive prostate cancer, reduced it by 27% after they were actually able to look at the prostate and the full tissue of it. So in one of the problems, though, with these DHT blockers is because cancer is very highly metabolic, and it does like to feed itself. And if you try to starve it of something, it's going to switch its metabolism to use something else. And we do find that with the DHT blockers, that sometimes if you block dihydrotestosterone, the prostate cancers will adapt and they'll start utilizing estrogen. So what they found in research studies that men with the highest levels of estrone and estradiol, which are types of estrogen, had a 45% and 49% increased risk. And so if you are on a DHT blocker, you could actually evaluate this by testing your estradiol, which is one of the main forms of estrogen floating around our blood. And you could also evaluate it by testing total estrogens. I got a question, one moment. NAD is, so NAD actually comes from niacin. And it's used as a cofactor in the electron transport chain. And it stands for nicotinamide adenine dinucleotide. You could actually get, Chip, thank you. And you could actually get precursors to NAD available as supplementation, such as nicotinamide riboside is one example. Continuing on though, one moment. So another factor is hypoxia, low oxygen. So in hypoxic or low oxygen conditions, because we use oxygen to help us create energy in the form of ATP, cells will adapt by turning cancerous and changing their metabolism. So rather than using oxygen, they switch to something called anaerobic glycolysis, and the mitochondria becomes dysfunctional. It starts losing its function. And instead of utilizing oxygen to create energy, they then prostate cancer cells switch to fatty acid beta oxidation. So this is why prostate cancer is a little bit different than cancers like leukemia that use sugar as their energy. Prostate cancer switched to using fatty acids from fats. And we'll talk about how important that is when we talk about diet later. And the problem is that rather than using oxygen to create energy, the oxygen is instead used to create reactive oxygen species or oxidative stress. And this is how, when we have low oxygen, it disturbs the microenvironment and contributes to further damage to genetic material and potentially the ability to lose that programmed cell death. In addition, when we have decreased mitochondrial function, it increases something called matrix metalloproteinases, or MMPs. And those play a role in tissue remodeling. So when we have an increased risk of tissue remodeling, we have a risk of potentially that overgrowth of malignancy. And we know this because in individuals with anemia, anemia is when we lose our red blood cells for various factors. And one of the components of red blood cells is a protein called hemoglobin. And what hemoglobin does is it transports oxygen. So if you have low red blood cells and low hemoglobin and low oxygen transport, well, in context of hypoxia, it does increase the risk of cancer by about 30 to 43%. So that's something where, if you are not getting your blood lab work evaluated through a doctor by doing a complete blood count and looking at your red blood cells, well, if you have anemia and if you're not managing that by addressing potentially either B vitamin deficiency, another reason why it's very important to get adequate levels of B vitamins, or if you're deficient in iron, and if you're not managing that and you're left in a low oxygen state, you're increasing your risk of cancer. So, one of the problems that I have is that some people are diagnosed with anemia. The doctor says, oh, you're anemic, you need to take iron. Some people that I've talked to, they'll take iron for a period of time. The doctor says, oh, okay, well, you're no longer anemic. And then people stop their iron, and then they never check their red blood cells ever again, or for many, many years. And then when I evaluate the lab work and I go, you're anemic, have you ever been told you have B vitamin deficiency anemia or iron deficiency anemia? I've had some people said, yeah, I was told that, but I took iron and it went away. Well, taking the iron, well, yeah, maybe it addressed an iron deficiency, but perhaps it didn't address the underlying factor that allowed that anemia to present itself in the first place. So monitoring your lab work, if you have a history of anemia, is very important to make sure you take the steps necessary to get you out of that state if possible. Not all anemia is caused just by nutrient deficiency, but the vast majority of it is. We also could understand hypoxia with sleep apnea, which is still often undiagnosed. Sleep apnea is when we have abnormal breathing at night, such as snoring. If your partner says that you snore horribly, you should get a sleep study to see if you have sleep apnea. Because if you're not breathing right at night, if you have obstruction of your respiration, and you're not getting oxygen, we see that it's associated with a 34% increased risk of prostate cancer. So managing that sleep apnea could be a very important strategy as well to make sure we're getting healthy amounts of oxygen to our mitochondria and to our cells. So I love barbecued food, but the problem is that when we cook red meat or other types of meat under high temperatures, it creates carcinogens. That Maillard reaction, those nice grill marks on steak, on burgers, that nice crust, unfortunately that creates something called advanced glycation end products and something called heterocyclic amines. And it takes only a very small amount of this to increase our risk. They did a research study where they found just 1.5 servings of pan-fried red meat per week increased the risk of advanced prostate cancer by 30%. The type of prostate cancer that we really care about because it can metastasize and spread. And they found in research studies that men who consumed 2.5 servings of red meat cooked at high temperatures were 40% more likely to have advanced prostate cancer. And by high temperatures, we're not talking about very high at all. We're talking about 300 degrees Fahrenheit or higher. In addition, a study evaluated evaluated almost 1,000 men, found that higher consumption of any ground beef was associated with a 130% increased incident compared to individuals who didn't or barely consumed it. In addition, there is some information that suggests eggs may be problematic, potentially due to a nutrient within egg yolk called choline. So there was a study that observed that men with prostate cancer who averaged just under an egg per day, meaning they potentially had 3 eggs per week, they had a 2-fold increased risk of prostate cancer progression compared to men who didn't eat any eggs. And in a 2011 study, men who consumed more than 2.5 eggs per week showed an 81% increased risk of prostate cancer compared to 1 egg per week. And it's likely mostly the egg yolk that's a component of that, because egg yolks are rich in choline, and we actually, instead of using radioactive sugar, like in most other cancers, and prostate cancer, because it doesn't really feed off sugar, we actually use radioactive choline to see if prostate cancer is spread to the bones. Because that prostate cancer within the bones is much more highly metabolic than normal tissue. So if it's taking in higher levels of this radioactive choline, we could see them glow brightly in the imaging report if they're spreading to the bones. So unlike cancers where they use radioactive glucose, they use radioactive choline to see if prostate cancer is spread to the bones, because prostate cancer loves fatty acids, and apparently it loves choline. Now, my colleague, Dr. Walker, presented this information to the same group 4 years ago. And at that time, it wasn't known so much if it was the choline or if it was more so just because the egg yolk is much more fatty substances. But unfortunately, since then, they've done research studies showing that even vegetarian choline sources are associated with higher cancer risks. So it's been much more established that it's the choline component that feeds prostate cancer, allows it to develop. But we'll see in a little bit how fats could be problematic too. For instance, in a 2013 study, they followed 21,669 doctors for 28 years. And what they found is that skim and low-fat milk was associated with an increased risk of low-grade cancer, but whole milk was associated with a 117% increased risk of progression of prostate cancer to more aggressive prostate cancer, to fatal disease. What they did not find that with is non-fat milk. So in other words, if you're going to be consuming dairy, you should be consuming non-fat dairy or potentially dairy alternatives, although there is a concern with some almond milks and soy milks have an ingredient called carrageenan in it, which makes it more viscous. And carrageenan is also a carcinogen, has been linked to potentially increased gastrointestinal inflammation as well. So if you are going to use dairy alternatives like almond milk and soy milk, just make sure it's a version that doesn't have a carrageenan in it. In addition, in regards to milk, I don't have a problem with non-fat milk. I'm not aware of any research linking non-fat milk to increased risk of prostate cancer aggressiveness. And one of the reasons likely why is because that fat is more likely to contain hormones and toxins as well, such as growth factors, xenoestrogens, etc. I have a question. Is there a downside to plant meats like Beyond Meats? Excuse me. That's an interesting question, and I don't have an answer to that. We'll see a little bit later on that vegan diets were associated with great benefit, but those diets were in a time before Beyond Meats and these animal product alternatives, as those are still very highly processed foods. And we know that processed foods are potentially also a link with prostate cancer. So I don't have an answer to those meat-based alternative products. I think we just don't have enough information yet, because they're still very highly processed. They're still potentially highly fatty. But on the other hand, some of them are soy-based, and we'll see later on how soy is actually a good thing. So I think really in regards to plant meats, I think that's an unresolved question at this time. I would anticipate the soy ones, though, the soy-based ones, are probably, if anything, beneficial, but I just don't know, to be honest. So here's a slide from one of Life Extension's magazines explaining how these foods that are rich in these fatty components can promote inflammation. For instance, red meat is very high in a fatty acid called arachidonic acid. And remember earlier that I said the prostate gland has an enzyme called 5-LOX that's very highly expressed into it. And what this enzyme does, this 5-LOX or 5-LOX oxygenase, is it converts arachidonic acid into pro-inflammatory compounds, such as, for instance, leukotriene B4. And these pro-inflammatory compounds potentially promote cancer, interfere with programmed cell death or apoptosis, and promote inflammation, such as prostate cell growth, for instance. So, I have a question for the audience. Do you believe that diet can reverse prostate cancer progression or reduce risk? And if your answer is yes, then you are correct. We can make dietary changes that help us. And you know, it's easy for me to suggest people take some supplement. It's very difficult, though, for people to change their lifestyle and their diet. It's very difficult for people to be compliant with dietary and lifestyle factors, unfortunately. But regardless, we could see still how it could be important for us to consider doing so if we're not already. So there was an Ornish study, and the Ornish diet is essentially a vegan diet. They were allowed non-fat milk a couple times a week, but otherwise it was a vegan diet. This was before Beyond Meats and those plant-based products. So these were people on a healthy vegan diet. And what they did is they took 95 men with biopsy-proven prostate cancer. And these men had chosen not to do anything about it. And so if we were to take these men and do a research study on them, in a lot of ways it would be unethical if we were forcing them to not do treatment. But these are men who already decided they're not going to do any treatment. So they took these men and they randomly assigned them to an experimental group and a control group. What they found is that after 1 year, the people on this diet, their PSA levels decreased, and the men who made comprehensive lifestyle changes. But the PSA levels increased in the comparison. Need a 1 minute break to drink some water. Now, to be fair, it's not just the diet that likely was a component to this PSA change. And for clarity, if we take men with prostate cancer who don't do any treatment, we expect over time that the PSA is going to increase. So the fact that actually went down is a substantial improvement. But in this study, it wasn't just diet that was a component of it. These people were actually going to weekly support group meetings too. So was it the diet that helped the PSA, the support group meetings that helped the PSA, or both? I don't have an answer to that. But that's another reason how going to conferences like this or having a support group could be a very important part of managing our lifestyle factors. Getting together with our peers, having a conversation, understanding is great for the mind-body connection and our mental health as well. So I can't say if it was the diet, I can't say if it was the weekly meetings I had, or the combination of both. Regardless, both the combination of both of those factors, regardless, is impressive. There was several different studies evaluating the Mediterranean type of diet, which is essentially a diet that's rich in whole grains, fruits, vegetables, nuts and seeds, olive oil, fish, and not much red meat and not much processed foods. So they did a study looking at 733 men with prostate cancer and compared it to 1,229 healthy men. Average age was 66 years old, and the study lasted 5 years. And they collected a range of data, such as their medical backgrounds, et cetera, and they controlled for that. And they put the participants into 3 groups: a Western diet, a prudent diet, and a Mediterranean diet. The Western diet included a typical American diet, a very convenient diet, high in fast food, processed foods, etc., a diet that most Americans are on. The prudent diet had low-fat dairy, fruits, vegetables, whole grains, chicken, and juices. And then the Mediterranean diet had a high intake of fish, fruits, vegetables, boiled potatoes, legumes, and olive oil with low levels of juice intake. In other words, this diet is less likely to have the development of insulin resistance. Juice loses the fiber component of fruits that blunts the increase in the glycemic or blood sugar response. And then they evaluated each diet with adherence, how well the people were doing that diet, very minimal, or if they were very highly strict in their diet. What they found is that only the diet that people were very strict in doing the Mediterranean dietary pattern, only that one was associated with a reduced risk of having prostate cancer, including aggressive and extensive tumors. No such link was found with the other dietary patterns with either aggressive or less aggressive cancers. In addition, in a different study of approximately 50,000 men that they followed for 24 years, they found that adherence to the Mediterranean diet was associated with a 22% lower risk of overall mortality or death from any cause. So a very healthy diet. And essentially what we're getting from this information, that switching from a diet that's very high in red meat, that's very high in fatty, fried, high temperature, barbecued foods, to either a vegan diet or Mediterranean type of diet is healthy for our prostate, healthy for our well-being, healthy for our cellular metabolism and our mitochondria. In addition, there was a recent study done in 2023 that examined 2,038 men, and they looked at them over 31.5 months after they were diagnosed with prostate cancer, over a 7.4-year period. And what they found is that the group that ate the most plants, the group with the highest plant-based dietary index, they had a 52% lower risk of progression of their prostate cancer and a 53% lower risk of reoccurrence compared to the group that ate the lowest amount of plants. And the interesting thing about this diet is that the amount of meat intake between the high plant group and the low plant group was basically the same. In other words, this wasn't a group that was reducing their meat intake. This was just a group that was just eating higher amounts of fruits and vegetables. What this study tells us is that even if you're not going to remove fats, even if you're not going to remove the barbecued meats, even if you're going to still consume red meat on a frequent, regular basis, you could improve your outcome of prostate cellular health just by increasing the amount of fruits and vegetables you're consuming. In addition, they found that in this group that consumed the highest amount of fruits and vegetables, they have even better outcomes if they incorporate it with exercise, such as brisk or fast walking more than 3 hours a week. So I want to briefly talk about a ketogenic diet, which is mostly a fat-based diet. Essentially, the body uses ketones as a fuel instead of sugar. When you limit carbohydrates or sugar so much, our body essentially switches the way it metabolizes energy. And there's a lot of interest in the ketogenic diet because when I mentioned Dr. Thomas Seyfried earlier, he's the one that brought a lot of attention to the metabolism of cancers in regards to the mitochondria information. And so he, as a proponent, suggests a ketogenic diet for a lot of cancers to control and regulate their growth. However, there's been no randomized controlled trials on ketogenic diet and prostate cancer, although there currently is a trial being done on those with active surveillance to see if it's helpful or not. The problem that I see with a ketogenic diet is that we know with research studies that prostate cancer is different than most cancers. It actually, instead of sugar, mostly uses fatty acid oxidation as a dominant energetic pathway. So if we have a diet that's mostly fat, the question is, well, is that going to be good or bad? Well, the ketogenic diet with the active surveillance group, that may give us more additional information, especially because that's not the whole picture, because there is some research showing that ketone bodies may be helpful in controlling cell differentiation and promoting programmed cell death. So maybe a ketogenic diet may be beneficial. We just don't know yet, so it's not a diet I suggest or promote in regards to prostate cancer prevention or treatment or management. Exercise is something that's very important. There was a study done on 52 men with prostate cancer under active surveillance, meaning that they had no treatment. They were just monitoring the PSA over time. And what they looked at is they did 12 weeks of 3 times a week supervised aerobic sessions, meaning running, jumping jacks, etc., something that uses oxygen. So they were on a treadmill and they went up to a very high level of peak oxygen consumption, meaning that it wasn't just some mild treadmill running. They were going pretty hard. The average age was 63.4 years. And what they found in this group that it not only improved their ability to use oxygen, it decreased their PSA. It also decreased their PSA velocity, meaning the amount of time it takes for the PSA to increase, compared to individuals who did not incorporate this exercise regimen. And what they found is that actually doing cell culture studies, it actually inhibited the growth of prostate cancer cells looking at them in a test tube. So any questions before we move on to the next section? Okay, I don't see any questions, so I'm going to move on. I'm going to have a Q&A at the end too, so if you think of any questions, we'll have some time to answer them. So now I'm going to briefly talk about advancements in diagnosis, monitoring, and treatment of cancer. There's some imaging techniques that are more effective in evaluating the prostate gland to see if there is cancer there, such as a multi-parametric MRI and a multi-parametric ultrasound. These are essentially using software to allow an MRI or an ultrasound to be more advanced. And the benefit with these imaging techniques is there's no radiation. They use either magnets or sound waves to look at the prostate. And what they found is that either one of these techniques is better than a standard MRI or ultrasound of evaluating the prostate. One reason why this is important is people under active surveillance, people with grade group 1 or Gleason 6, who are just going to be monitored over time. It is important to continue to do imaging because sometimes cancer does become more aggressive. Sometimes that Gleason 6 or grade group 1 can change into a grade group 2. And that does happen in about 15% of the time. So that's why it's called active surveillance. They need to continue to be monitored to make sure that the cancer doesn't become more aggressive and then requires some type of treatment. So continuing to do imaging is quite important. And the reason why I put the slide here is because there was a study, and what they found is that when you combine both of these tests, it's the best situation because the ultrasound could detect cancers that the MRI can't, and vice versa. The MRI could detect cancers that the ultrasound can't detect. So if you are suspicious of prostate cancer and you get an MRI done that doesn't show anything, well, definitely the next step is to get an ultrasound, ideally a multi-parametric ultrasound, to see if that shows something. I'll briefly talk about biopsies. A lot of people that I talk to are concerned about prostate cancer biopsies spreading cancer. And that's true of some cancers, such as liver cancer, but it's not true of prostate cancer. They did research studies. They have found that prostate cancer biopsies do not result in cancer seeding or metastasis. In addition, we could send out those prostate biopsies to do genomic profile. For instance, Polaris could see how aggressive it is. So that goes back to the initial question, well, do you treat it? Well, if you have a Gleason 3+4 or grade group 1 that may be aggressive, well, if you do Polaris testing and it says that it's a non-aggressive cancer, well, that leaves me more inclined to be putting that person in active surveillance type of category rather than cutting and blasting them. In addition, they found that MRI-guided biopsies result in better diagnosis, approaching removing the prostate or part of the prostate, such as a TURP, essentially, rather than just going in there and guessing and taking 12 different random samples. If you get in there with an MRI and if you see a nodule or a lesion and you could biopsy that, well, that results in much better diagnosis rates. And there's a relatively newer way of doing a biopsy called the transperineal biopsy, meaning that rather than going through the rectum, they go through the area between the penis and the rectum called the perineum. And it has the same capability of detecting cancer compared to a transrectal biopsy, but with much less risk of infection. Because if you're going through the rectum, you have the risk of that fecal bacteria penetrating through into the prostate and creating an infection there. Well, you substantially can reduce that risk by asking for a transperineal biopsy. So I'll talk about active surveillance because until about 10 years ago, most men with low-risk cancer had treatment. They had surgery or radiation. But Now, with a recent study, we found that around 60% of low-risk men are now under active surveillance. And the amount of those men that are under active surveillance has significantly increased in this period of time. And so one reason why people in grade group 1 or Gleason 6 can undergo active surveillance is because those type of prostate cancer cells resemble normal cells in most cases. And so what they found is they did a study of 18,000 people with grade group 1 under active surveillance. And what they found is a 0.1% mortality at 10 years and 15 years. But they did find that there was grade reclassification around at the 5-year mark of around 21%, meaning that that grade group 1 increased to a grade group 2 and then potentially then need to be treated. So that's why it's active surveillance, not cure. We're still monitoring these people. But they did a study of 2,900 people, of which most, but not all, were grade group 1, meaning that some are grade group 2, some are grade group 3. And what it showed is that only about 1.5% of them had a metastasis after 15 years. So that's one reason with these low-risk groups that we could just monitor them over time, continue to do biopsies, continue to do imaging to make sure they stay in a low-grade group. In addition, there's now some focal therapies. So rather than doing a radical prostatectomy, rather than doing a substantial amount of radiation, there's nowadays some alternatives, such as cryotherapy, where they could freeze the prostate cancer, or high-intensity focused ultrasound to use sound waves to destroy cancer. And they have pretty good results. For instance, in a UCLA study using cryotherapy, they found that after 6 months, 80% of patients had no signs of cancer. The same with 18 months later. And with the high-intensity focused ultrasound in 100 patients at USC, they found 91% were able to avoid radical treatment for at least 2 years, and that 73% of them did not experience treatment failure. And there was a 100% continence preservation rate. These people didn't have issues with the urinary system afterwards, which is common in radiation and prostate removal. In addition, there's more advanced imaging techniques to see if prostate cancer has spread, called a PSMA. It stands for prostate-specific membrane antigen. They inject you with a radioactive molecule that attaches to prostate cancer cells, because prostate cancer that has spread to the bones, for instance, is still prostate cancer. So this is a more advanced way to see if prostate cancer has spread. It's 24% more sensitive than a multiparametric MRI. In addition, one of the benefits of the PSMA scan is if they do find cancer that has spread, there's PSMA drugs that are available that also attach to the prostate membranes that could target them, such as Ofigo and Pluvicto. So if you have prostate cancer and you're concerned if it's spread elsewhere, ask your doctor to do a PSMA, because it's much more valuable than a regular MRI or CT scan and looking for spread. In addition, if an individual is going to undergo radiation, there's a relatively newer option that could protect the rectum from radiation called SpaceOAR. Essentially provides a barrier between the prostate and the rectum. And there's much less urinary complications and much higher quality of life in individuals using SpaceOAR. So if you are ever going to require radiation in the future, ask your doctor if they could use the SpaceOAR hydrogel to provide a barrier to protect the rectum. So in the remaining of our time, I'm going to talk about clinically validated nutrients. Supplements are nutrients that could be supportive of helping to support healthy cell division and differentiation of the prostate. One of them is vitamin D3. Very important to have adequate levels of vitamin D3. Now, going back to a question asked earlier, having too much vitamin D3 is not a good thing. For instance, levels above 100 nanograms per milliliter could lead to calcium leaching out of the bones and getting into structures and leading to be calcified like the heart. So we don't want too much vitamin D. That's why it's important to have your doctor test your vitamin D, because they looked at a trial and 48 black men and Caucasian men with low-risk prostate cancer. They gave them 4,000 IUs for 1 year, and the standard suggestion is 600 IUs. But I find that most of our people that we talk to take between 5,000 and 8,000 IUs to get optimal levels. And what they did is under that period of time, 19 men were diagnosed with prostate cancer. They underwent biopsies at very similar intervals compared to controls. And what they found is that the individuals who were taking the vitamin D, they had fewer cancerous cores in their biopsy tissues, or they had improved Gleason scores after 1 year, meaning that they had potentially higher grade cancer cells that went to lower grade cancer cells after 1 year. So that's quite impressive. And we like vitamin D levels between 50 to 80. CoQ10, that goes back when we talked about earlier about, well, if you give CoQ10, it's going to feed cancer cells. Well, we have to support the surrounding microenvironment. They took 104 healthy men with low PSA, and they were randomly assigned to have 400 milligrams of CoQ10 per day or a placebo. And what they found is that the CoQ10 actually significantly reduced their PSA levels by 33%. And one of the ways that does so is it scavenges free radicals and helps support healthy mitochondrial function. And our CoQ10 levels decrease with age. That starts to occur around age 20, but you could actually test your blood CoQ10 levels to make sure that you have a good, healthy amount in your system. We like that to be between 3 and 7. There's a lot of research on green tea supporting healthy cell division and differentiation. For instance, in a meta-analysis of men with high-grade prostate cancer, taking green tea reduced the rate of progression from pre-cancer to cancer from 23.1% down to 7.6%. In addition, in a randomized trial, 113 men diagnosed with prostate cancer was assigned to either drink 6 cups per day of green tea, black tea, or water for at least 3 weeks prior to a prostatectomy. And what they found is that the PSA levels significantly decreased in the group consuming green tea. And another study, individuals taking 800 milligrams of EGCG, a polyphenol from green tea, they had decreased levels of PSA and other cancer markers in the blood, and their biopsy confirmed prostate cancer before they got a prostatectomy. Excuse me. Lycopene comes from cooked tomatoes, and it has both heart and prostate benefits. It's a fat-soluble component, so that's why it's mostly released in cooked tomatoes, for instance, pizza, spaghetti, etc. And what they found is that increased dietary intake of lycopene was associated with a decreased risk of prostate cancer, especially lethal prostate cancer. They found that a high intake of tomato-based products was associated with a 10 to 20% decrease in prostate cancer risk. One of the ways that it could help so is to manage angiogenesis, the formation of those new blood vessels. Curcumin. Actually, there's not a lot of studies in curcumin in prostate cancer, which is disappointing because there's a lot of studies in other forms of cancer. It controls inflammation, it controls apoptosis, but really there's no good studies in curcumin in prostate cancer. There was one where it showed that it slowed PSA velocity, but it didn't have an effect on the overall PSA levels. But I would argue that was likely because the study was way too short of a duration. So this is information we're still waiting on, is good, high-quality curcumin studies. But the reason I put the slide in here is because there's a lot of studies in other forms of cancer showing benefit. In addition, it makes sense from a theoretical perspective, as it does help to inhibit inflammation. Pomegranate. So they evaluated 92 men with low-grade prostate cancer, and they were taking 1 gram of pomegranate extract per day. And for these men, their average PSA doubling time was 12 months. And after 6 months of taking the pomegranate, that increased to 19 months, meaning it took 19 months for the PSA to double rather than 12 months. In addition, there was one trial where the average doubling time increased from 15 months to 54 months in men with rising PSA levels after surgery or radiation therapy, meaning biochemical recurrence, meaning the prostate cancer return, because the PSA levels after surgery or radiation should essentially be 0 afterwards. And then in a randomized trial in a similar patient population, they found that doses between 1 and 3 grams of pomegranate extended PSA doubling time by 58% and 43% respectively. And that was statistically significant. This is a nutrient where perhaps there's the most amount of research studies. Over 80 published clinical studies, modified citrus pectin. This has 2 main benefits. It helps to promote programmed cell death or apoptosis, but it also regulates the spread of cancer by binding to galactins, a protein that cancer cells can attach to, and this protein our body naturally produces. But modified citrus pectin could also bind to galactins, and if they bind to galactins, there's less of this protein available for prostate cancer to attach to and be spread around. So there's a lot of studies on modified citrus pectin, definitely one of my favorite nutrients for people who have prostate issues, especially concerned with the potential for prostate metastasis or individuals who have metastasis. So There's a lot of studies. I'm not going to go over the studies, but this is something where definitely if someone has a concern, it's definitely a top suggestion I would have. And this is a slide just showing how it works. Essentially, the modified citrus pectin binds up to that galactin-3 protein so that it's not available for cancer cells to attach to and be spread around. There was a study that was published in the American Society Center of Oncology where they evaluated 199 men with prostate cancer. The average age was 74, and they were randomized to either get a capsule that had pomegranate, green tea, curcumin, or turmeric, and broccoli, compared to a placebo or a sugar pill. They took it twice a day. What they found in the placebo group, the PSA levels rose by 78.5% over the 6-month period, but in the supplemental group, the PSA rose by only 14%. So it significantly slowed down the PSA velocity. I apologize, the ASCO stands for the American Society of Clinical Oncology. Soy. So this goes back to the question someone asked, well, are soy-based processed products like those meat alternatives beneficial or not? Well, although I don't know, it's theoretical they could be, because in research studies using soy isoflavones, they found it to be helpful because even though it's a phytoestrogen, what it means is it actually blocks potent estrogens from binding to estrogen receptors. And what they found in individuals who were using soy-enriched bread or soy-based products is they found reduced markers of inflammation, reduced markers of cancer-promoting immune activity. And in one trial that had 54 patients scheduled for a prostatectomy, the individual receiving 30 milligrams of a soy isoflavone called genistein had a 7.8% drop in PSA levels compared to a 4.4% increase in the placebo group. Cruciferous vegetables such as broccoli are so helpful for regulating healthy cell division because one of the things they do is not only help to promote environmental detoxification, but also hormonal detoxification as well, such as potent estrogens. And so in one small clinical trial, 20 men with prostate cancer took a cruciferous vegetable-rich broccoli extract for 20 weeks, and they showed that the PSA doubling time increased during that treatment, meaning the time that it took for the PSA to double. So in other words, they had a reduction in the increase in their PSA in that velocity period. And in a meta-analysis, what they found is that individuals who consumed more cruciferous vegetables were associated with a 20% reduced risk of prostate cancer compared to those who ate the least amount of cruciferous vegetables. We're waiting on 4 clinical trials that are examining cruciferous vegetables in prostate cancer, so that information should be promising and coming out hopefully in the next couple of years. In one study, men who are at risk of developing prostate cancer ate either 400 grams, which is about 2 cups of broccoli, or 400 grams of peas per week, in addition to their normal diet. The study was done over 12 months, and samples were taken from the prostate gland before the start of the trial and after 6 and after 12 months. And what they found is that there were significant changes in the gene expression in the broccoli-rich diet compared to the pea diet. And this goes back when I talked about the influence of epigenetics on our genetic risk factors, and that we could take steps with our diet and our lifestyle to influence the way that our genes are expressed and change that genetic expression. Cranberries have been shown to be helpful, perhaps by regulating the microbial environment, but also likely to do a role in potentially managing inflammation. In one trial, they had 64 individuals scheduled for a radical prostatectomy, and they took either 1,500 milligrams of cranberry fruit or a placebo for at least 21 days prior to surgery. And they found that the PSA levels decreased by 22.5% in the group taking the cranberry compared to increase in the placebo group. In addition, in a randomized controlled trial in 370 men who had radiation therapy, those receiving 200 milligrams of cranberry had a lower rate of urinary tract infections compared to placebo. Because one of the problems with cranberry, with radiation, is it promotes inflammation of the bladder and the rectum. And inflammation promotes an environment that is favorable for undesirable bacteria to flourish. Fish oil. We found that men consuming the highest amount of fish compared to a traditional Western diet, that when they evaluated the prostate cancer cells and they exposed those to the blood taken from the men eating the fish, they found significantly decreased growth of those prostate cancer cells in the cell culture studies. In addition, the second analysis of that study found that the pro-inflammatory markers were decreased and scores on their prognostic testing were more favorable in the men eating the low-fat plus fish diet compared to the standard Western diet. In addition, in a study in men with low-risk prostate cancer undergoing active surveillance that had higher levels of omega-3 fatty acids, they were associated with a reduced risk of prostate cancer progression. So now and last, I'm going to talk about using drugs, conventional pharmaceuticals, to target prostate cancer cells. So metformin is normally used to manage diabetes, to help to regulate blood sugar control. But they've actually done studies or individuals who have diabetes and were on metformin actually lived longer compared to non-diabetics not on metformin. And they did a study where they took 3,837 men with prostate cancer and diabetes. Their average age was greater than 66 years. And over a period of about 4.5 years, 35% of them died, and 7.6 as a result of prostate cancer. What they found is that every additional 6-month interval of metformin use was linked to a 24% decrease in prostate cancer-specific mortality, and a significant decrease in all-cause mortality. And essentially, the longer they were on the drug, the better they did. So if you are at risk of prostate cancer or you have prostate cancer, it's worth asking your doctor for a prescription for metformin. Generally low adverse effects, gastrointestinal side effects can last about a month. They typically go away, and it can deplete your B12, so make sure you're taking B12 if you're on metformin.
Could I ask a question?
Sure.
About metformin? Could you go back one slide? It said there that the patients or the cohort group had prostate cancer and diabetes.
Yes,
and
correct.
When I was younger, in my 20s, my late teens, I had a couple of GTT tests, and I had hypoglycemia. I did have insulin reaction, but it came at a different time than normal. But now, at 76, I don't know what my glucose tolerance is or my insulin resistance. Would metformin be advised even before you know whether you are pre-diabetic or if you have insulin resistance or not?
Yes, in fact, in our conversation with people at Life Extension, we encourage healthy people who don't have blood sugar issues, who are concerned with their longevity, to ask their doctor about metformin, even if they don't have cancer, due to its potentially to overall extend lifespan.
Well, then I have one other question. My urologist oncologist does not want to prescribe metformin for me. He says you're not diabetic and it may not make any difference. Although my general practitioner, if I had evidence of being pre-diabetic or some insulin anomaly, might authorize the metformin. But am I in an ethical quandary there because I've got one doctor giving me metformin and another one doesn't want to give it to me?
Well, it is sort of an ethical quandary because here's the problem. In standard conventional medical care, oftentimes if you go against the doctor's advice or do something different than what they're suggesting, they typically will remove you from their care. So that is something we have to be cognizant of. There are organizations that will allow you to get access to metformin if you have a concern with cancer. But generally speaking, if you tell your doctor who doesn't want you to be on it that you're on it, you do have a significant risk of being kicked off their care and having to find a new doctor.
Life goes on.
Life goes on. So in essence, some people therefore try to find more of a functional or integrative oncologist. However, those tend to be much rarer than standard oncologists. Definitely a type of privileged thing to be able to have access to. But essentially, we also have a research study on non-diabetics who used metformin. There's a study of 87,344 U.S. veterans who were using androgen deprivation therapy for advanced prostate cancer. And they found that the men who had diabetes had an 80% decreased risk of death compared to men who did not have diabetes and were not on metformin. But even in the men who did not have diabetes, the metformin also had a decreased risk of death. They also found an 18% decreased risk of skeletal-related events and a 30% decrease of cancer-related death in that period of time. Aspirin is another new, medication that could be supportive. There was a study of 22,000 men from 1982, and those with prostate cancer took more than 381 milligrams or baby aspirin per week, and they found that those men had a 24% lower risk of getting a lethal prostate cancer, which, if you realize that aspirin reduces inflammation, and inflammation is a root factor in all chronic degenerative conditions, well, that just makes sense. And they found that regular aspirin use after diagnosis was associated with a 39% lower risk of dying for prostate cancer. But what they found is that the use of aspirin before diagnosis didn't have any measurable further benefit. In other words, once the cancer has occurred, then adding in the aspirin to manage inflammation essentially slowed or lowered the progression into a lethal prostate cancer. And so there's a study called Aspirin, which is a phase 3 double-blind placebo-controlled randomized trial that's going to assess the effects of aspirin on disease reoccurrence and survival after primary therapy such as radiation or prostatectomy and common non-metastatic solid tumors. And that's evaluating out of those 2,120 prostate cancer patients. And so when we get the results of this study, it'll give us even more information on the usefulness of aspirin. And last,
I have one question about the aspirin.
Mm-hmm.
I do, in fact, I used to, before I knew any better, take aspirin. I'd take one whole aspirin a day, and I ended up after about 2 weeks having tremendous nosebleeds almost every day. And somebody told me, well, you're only supposed to be taking a baby aspirin, 1/4, 81 milligrams. In your previous slide, it didn't say what kind of dosage you should be using.
Well, here's the problem. Well, in one of the studies they took more than 381 milligrams. So I believe standard is either 325 or 350 milligrams.
325.
325. So yeah, they were taking much less of that, and they were only taking not every day of the week, but just several times of the week. Well, here's something to consider: is that aspirin does have its risks. As you mentioned, with those higher doses on daily use, you do have the risk of blood thinning capabilities. But even with baby aspirin, you do have the risk of stomach ulcerization. And so one thing that they found, though, is that the inflammatory and the blood regulating effects of aspirin are actually a lot more long-term than previously recognized. We could actually find very similar benefits using 81 milligrams of baby aspirin every other day in regards to platelet aggregation and inflammation. So that's a dose that I would suggest for people who are considering using aspirin is a baby aspirin every other day.
Well, I also have an occluded carotid artery that's blocked on one side, luckily only one side. And so I'm taking a baby aspirin in the morning and a baby aspirin before I go to bed at night. And so far, I don't seem to be having any adverse nosebleeds or any other bleeding problems. So should we just go? I'm not asking if should a person just kind of estimate, watch what's happening and see if there's an adverse reaction, and if everything seems to be working okay, just keep doing it?
Yeah, I would agree with that statement, generally speaking. Mm-hmm.
Okay.
And if stomach ulcerization does occur, if people notice blood in the stool, well then the aspirin could be stopped until a period of time of recovery and then perhaps resumed in a lower potency or dose. And there are botanicals that may help to support the stomach mucosa, such as PAW-D-ARCO, which could help to manage stomach inflammation and support the mucosal lining of the gastrointestinal tract. So someone who is taking daily aspirin, I encourage them to consider using PAW-D-ARCO, which is available either in tea form, but I heard it tastes nasty, but you could get it in capsule form. Statins. Now, one of the problems with statins is that it can deplete CoQ10. So anyone on a statin should be taking supplemental CoQ10. But statins could actually be very helpful, and likely one of the ways they're helpful is by managing inflammation. In fact, some research suggests that some of the heart benefits of aspirin are not from its ability to reduce cholesterol, which does have some benefit in cardiovascular disease, but actually more so its ability to regulate blood vessel inflammation. And what they found is that among men with prostate cancer, those with high cholesterol levels are more likely to have higher grade prostate cancer, more likely to have metastasis. And they found that men using statins to manage their cholesterol had a lower risk of advanced prostate cancer and a higher rate of prostate cancer survival. And it may work via modulation of cholesterol signaling pathways, and it may work by modulating inflammation as well, and it may also influence enzymes that participate in cell migration and tumor progression. So an individual who has a risk of cardiovascular disease and also has prostate cancer, statin is something that even as a naturopathic doctor, I encourage people to consider. And so that's the end of my presentation, and I'm open to any questions that anybody may have.